Hello, I'm Dr. Donald Jurovich, UND Professor of Geriatrics. This is part 2 of the 4M framework on mobility. And this presentation, we're going to focus on fall risk assessment and action plans or management of screen negative and screen positive older adults. Just a little bit of a nod to a incredible older adult with balance, Carl Walunda. Regrettably, he fell off the high wire and fell to his death. But just a remarkable family in terms of being a high wire act for many generations. Just as a reminder, please, if you get a chance to access the Dakota Geriatrics website for educational materials, including this presentation. This is a HRSA-funded project for the Geriatric Workforce Enhancement Program, and we also call it the GWEP, although some people like to call it the GWEP. So the goals today are to focus on consistently applying the rapid fall risk assessments in our patients with each clinical encounter. If they screen positive, we want to evaluate the multifactorial mechanism for the fall risk and try to mitigate that. So that's basically item 3 is to create action plans for older adults, both those who screen negative, so that would be primary prevention of falls, and then those who are screen positive for fall risk. So we want to consider the rapid screen versus a little deeper dive in terms of the fall risk evaluation. So Medicare actually will allow people to use self-reporting of falls within the 6-month window, and that in itself is useful. However, not everybody wants to report that they had a fall, or they don't consider it that big of a deal, and they don't want to bother the provider with that information. So it's not a consistent or reliable methodology. The other 2 quick screeners, and there's many of them, I'm just representing the ones that many geriatricians use in their clinical practice. And the first one is the Sharp and Romberg. We'll learn about that. That's basically a full tandem, one foot in front of the other foot posture. And then the second one, which is what we advocate, is to use gait speed. I tend, for simplicity purposes, to use 1 meter per second as the cutoff for those who are at risk for falls and those who are not. You can kind of get a sense here with color coding here, where based on age-matched controls, where people with 0.8 meters per second and less are at incredibly high risk of falls. And those are the ones that we typically like to refer to a multidisciplinary fall prevention clinic. But I'm an advocate of using 1 meter per second as that cutoff. The other point to be made is that there are static and dynamic balance evaluations through structured evaluations. You may hear about the Tonetti-Gayton postural balance test. I think more commonly people are using the Berg scale for measuring the degree of fall risk, and also to use it as a measure of improvement over time. It's very similar to how we use the rapid screen for depression of the PHQ-2, and then morph into the PHQ-9 as not only a screening tool or an assessment of their depression level. It allows us to see and score sequentially or chronologically to identify whether there's been improvement, no change, or deterioration. So the Berg scale is very similar in that, and you'll see how that score works and how we can use it to track older adults over time with their, like I say, with our interventions for fall mitigation. So just to get into the Berg scale, there's 14 tests typically conducted by a physical therapist. Each of these performance tests are scored with 5 different points ranging from 0 to 4. Obviously, with the 14 times 4, you get 56 maximum score. And you can see the interpretation here. One of the tests I just put here, I mean, they include gait speed. They also include the 5 times stand sit test, and it's timed, and there's a nomogram for that. And there's other postural measurements that they take. So it's a composite score. The Berg score, on average, declines with increasing age. So again, you have to have a normogram to compare a 90-year-old to what you would expect for fall risk, right? But the important point is that because these are physical performance functional tests, the Berg score is reflecting that as the population gets older, that there are increasing risks for fall. So that may not come as a surprise, but you can sort of get a sense of how that decline starts to occur once people reach and go beyond the average age of life expectancy, which is 81 years of age in the United States. So I just wanted to walk you through the Sharp-Romberg. It's a tandem stance. And just to give you some caveats, so we do the Romberg test, right, and then we go into the Sharp-Romberg test, and again the 1 foot in front of the other foot, as we can see here in this picture, and they ask to crisscross the arms on the chest, which I don't do because, quite honestly, with a lot of frail older adults, you will notice that they won't be able to hold the stance for barely a couple of seconds before they start getting wobbly. And so it's important to stand next to the individual. We don't see that here because it's a younger person, but as a provider, you want to stand next to the person. And sometimes I'll grab onto their back belt and I let them know I'm doing that. And or I'll have my hand around ready to catch them if they really get very, very unsteady. And you want to do the test firstly with the dominant leg as the back foot, and then you can switch it out and see if there's issues with the non-dominant foot as the plant foot. So that's the skinny on the Sharp-Romberg test. So it's a rapid screening test, and just as a positive screen would be the inability to hold the stance for 10 seconds or longer. So that's how that goes. And the other reminder is that you do the test with eyes open and eyes closed. And again, in my clinical experience, individuals that are screened positive for the tandem stance or Sharp-Romberg test will manifest that with their eyes open. But again, the second phase of that is to have them close their eyes and do the test. Okay, so if we screen positive for fall risk, the question is, how do we approach the patient? And the first thing is to consider a review of systems. You firstly want to establish the fall's relationship to rising from either supine or sitting position, how closely they had the fall relative to taking their medications, and importantly, how closely the fall occurred after eating, because of the concept of postprandial hypotension. We also want to ask about environmental factors, slips on rugs. Usually it's a change from a hard to a soft surface. And so we want to know those areas of transition in the house or living quarters. We also want to ask whether they felt some generalized or whether there was local weakness. My left knee gave out on me, for example. We also want to add to that lightheadedness or vertigo, and in particular, if there's any position that they like looking up that might suggest lightheadedness while turning their head or looking up, that might be associated with vertebral basilar artery insufficiency. And then often overlooked is the question of alcohol consumption. And I always remind people that alcohol metabolism really creates a 2-for-1 rule, where one alcoholic drink actually is equivalent to 2 alcoholic drinks just because of the reduced metabolism with increasing age. The physical exam is focused. Obviously, you want to listen to the heart for aortic stenosis murmurs, but and you'll want to do maybe a walk test to see if they desaturate with their oxygen. But in terms of the focused elements here, cannot underestimate the importance of vision, contributing to falls, particularly the contribution of progressive eyeglass wear and bifocals. Cerumen impaction, believe it or not, is a contributor to fall risk as well as hearing loss. In terms of the motor exam, I like to do the shoulder shrug to identify any central motor weakness that might occur with different conditions, most commonly changes in calcium, particularly hypercalcemia. I also look for bilateral or unilateral cogwheeling that might suggest that the extensor muscles are or have been disrupted by either a stroke in the midbrain or through Parkinson's disease. In terms of strength, all muscle strength should be evaluated, and I particularly focus on the flexion extension of the greater toe to look for L5 and S1 radiculopathies that are often underreported. And also you want to evaluate the range of motion, both in terms of the back. So I use the psoas stretch with the person lying on their stomach. And so you look to see how much excursion that they have, and you can see on the right-hand side here the goniometer, which we don't typically use, but that's if you really wanted a very robust measurement of that hip extension, you can measure it that way and possibly use that measurement for future use for a flexibility plan that you might put in place with physical therapy, and then reevaluate whether that degree of excursion had improved. The other elements, of course, we're focusing on the neuromotor exam, and on the neurological part, we want to establish whether there's loss of vibratory sense. And just as a clinical pearl, is if the individual complains of vibratory loss in both hands and feet, you need to think about heavy metal toxicity. In terms of proprioception, it's important to know whether they not only can feel where their feet are, but where they're located. And then the big one is mental status testing. So that's why we always include the either the slums test or MOCA equivalent for identifying memory loss and loss of executive function, which is the signature change that occurs in dementia. So in terms of the action plan for those that screen positive for falls, we want to address the eyewear, make sure that they exchange their progressives or their bifocals for monocular eyewear. If there's cerumen, we disimpact. We, most importantly, prescribe resistance training in addition to core balance exercises. We also include flexibility interventions as well as aerobic interventions, but the flexibility is less evidence-based. It just, if you see somebody that has joint muscle stiffness, often you consider it as being a contributor to their postural instability, but no current research to indicate that that's the primary driver for falls. The other question here, and most importantly, is to make a referral. So in our clinic in Sanford, we have the fall prevention clinic. We also have a geriatric consult clinic. So either one of those could be a referral. And then also to consider a referral to a community program. Those are typically programs called Stepping On or Bone Builders, and we'll talk a little bit about how you can make those referrals. But basically, it's a going to what's called the NDC3 website, and they will list fall prevention programs and overall exercise programs for older adults within each community throughout North Dakota. And I believe South Dakota is also trying to develop a similar referral. The other thing to consider is for fallers as to whether they need an assistive device. A lot of people are reluctant because they look like an old person and they don't want to use a cane. Well, doggone it, you have to sometimes have a discussion. And that discussion might include consideration that grabbing onto something, such as a cane, steadies the brain, not only the body. And so there's an improvement in postural sway. So that whole business of going anterior, posterior, and lateral sway, that starts to reduce when you grab onto something, because the brain is telling the body that we have stability. So the assistive devices can be very important. There's some new evidence that Nordic sticks for walking improve overall responses to physical activity. The vitamin D story is perhaps controversial in the ambulatory care setting, but it certainly has demonstrated impact with supplementation at 1,000 units daily for reducing falls in long-term care. And then another evidence-based intervention is the home environment check, which can be done through home nursing or perhaps a paramedic consult, or even the home-based primary care program that we have in our internal medicine program at Sanford. So what about people that have screen negative? Well, that becomes prevention. So they don't express that they had a fall, and they have good balance on all our rapid screening tests. It would be valuable to, again, refer them to the ndc3.org, which will provide information in their community as to whether there's a stepping on program or bone builders program. And some of the communities also have silver sneakers programs, which also is a not-for-profit organization that helps with overall physical activity for the older adult. You also would want to consider prescribing home-based programs and using the cores of the elements of resistance training, which is most important, remembering that it's 1% lean body mass loss annually per older adult per year. And so that's the importance of resistance training. It should be done twice weekly, and minimally, I should say. And then also provide a core prescription for core training as well as endurance. So I just wanted to share with you some of the emerging concepts. One is called dual task training, and so this is kind of represented here in the stick figure, where when you're walking that you do cognitive tasks such as counting backwards or saying the alphabet backwards, or even spelling words. And what that does is it disassociates the brain from the spinal cord balance mechanism, and for whatever reason, with aging, that the spinal reflex for postural balance deteriorates and needs to be stimulated. I don't know whether it's disuse atrophy or what the mechanism is, but it's been demonstrated that dual task training does significantly improve postural balance and responding to perturbations in gait. And then the second one is listed here as what we call single session gait perturbation, and I'll show you how people are thinking about that. So here's the evidence that dual task therapy, when you say dual task therapy, that means counting backwards while you're walking simply. You just need to do it for a few minutes each day. And you can see with the dark gray zones here that the gait speed, in this case, improved substantially. And then this is an example actually of a collaborator of mine, Dr. Clive Pay, who has this contraption. But basically what occurs here is that the older adult will be on a treadmill, and you can see that they're suspended by bungee cords or safety harness. And at different intervals while walking, the rug will be pulled out from under them, so to speak. And that causes a a fall. And you can see that for all the studies that have done this kind of perturbation training, which, by the way, you can replicate by throwing a medicine ball at an older adult, having them catch it, not throw it at them, but having them catch a medicine ball. And again, on a harness so that they don't fall with injury. But you can see here the little red dots in the overall diamond here showing that the intervention reduces fall in the intervention group. So that's something to consider as that evolves into the clinical setting. So I'd like to just summarize that we know that age alters both posture, gait speed, and our recovery strategies. We need to be mindful of that and always be on the lookout for fall risk, and we can do that through gait speed. Again, I use 1 meter per second as my cutoff, and also to apply the Sharpen-Romberg. So if, for instance, the nursing staff was unable to get a gait speed for you, you can certainly address the 4M assessment through the Sharpen-Romberg test. And then the action plan is multifactorial. The best evidence is referring the patient to a multidisciplinary fall prevention clinic, but you can also make referrals to physical therapy, as well as yourself as a provider providing an action plan that entails resistance training, core training, endurance, and flexibility. And we'll talk a little bit about that in part 3 of this presentation regarding the mobility plan. So just to summarize, if somebody has a gait speed of greater than 1 meter per second, refer them preferentially to community-based programs utilizing this NDC3 website here in North Dakota, and to be determined in the South Dakota region. Create a mobility plan, which we'll talk in part 3 here of this presentation series. Include a home safety check, and that home safety check can be a self-assessment, and the CDC and the National Institute of Aging have home safety check lists. Make sure that they're taking or have adequate levels of vitamin D, and then also to consider changing out the eyewear to using, if they need distance vision, for monocular eyewear. And then the fall risk screen positive, as we see in the red here, less than 1 meter per second for gait speed, or positive Sharpen-Romberg test. Preferentially, we'd like to refer them to a fall or geriatric consultation. Same thing with them is to change out their eyewear. Consider the application or revision of an assistive device. Just to share with you, I had a patient in clinic once who had a rolling walker, and neither brake worked, and so when she went to apply the brakes, she fell flat on her face. So just doing an equipment check sometimes is part of the evaluation. Again, a home safety check, supplemental vitamin D, and then once again, creating a patient-specific mobility plan, oftentimes in concert with the physical therapist and or a personal trainer, depending upon the ability of the older adult to afford that, because of course Medicare and Medicaid do not pay for personal trainers. So with all of that in mind, I appreciate your attention, and I look forward to your application of the geriatric 4Ms with each clinical encounter, to include the fall risk assessment, and then to pair that up with the mobility plan. Thank you.